Hello, thank you for joining me today for a technique comparison of myofascial release. Today we will be comparing 4 different myofascial release techniques and specifically their application in a clinical setting. This session will not spend too much time on the theories behind each technique, as most theories have been covered in a previous installment of myofascial release program. If you would like to stop your audio right now and print off or pull up on a dual screen the Poplet that has been provided on the link in this assignment, it may help you to follow along. As we begin today, we will look at positional release, pressure release, active release, and dry needling. You will see that each technique has some similarities, and there are subtle differences that make each one applicable in different settings. First thing I noted in a sub-bullet here is the patient versus clinician involvement. This is purely opinionated based on my readings and my previous experience in the clinical practice. In looking at positional release, we can presume that the patient will have a little bit more involvement, a little bit more voice. Same thing with active release. We want the patient giving the clinician feedback. Whereas with pressure release and dry needling, these are mostly clinician controlled and require very minimal patient involvement. So let's get started to break each one down. With tissue treated, we know that myofascial release looks at both trigger point and tender points. So in positional release, we can treat both trigger points and tender points throughout the whole body. It is presumed best to create or apply this technique with a whole body examination. This is a unique aspect of this treatment. Instead of just treating one body part or one muscle group, it is encouraged that the whole body is examined before any application. Looking at pressure release, this tissue treated will focus mostly on myofascial trigger points. Active release will focus on tender points, which are areas that are tender to submaximal pressure applied by the clinician. These tender points are located throughout the body and are present in muscle and tendons. This is different than a myofascial trigger point, which is located just in the muscle. And lastly, dry needling will focus on the myofascial trigger points. So seeing that there is overlap in the treatment or the tissue treated, we then want to look at the underlying mechanism to help us decide which treatment is best for our patient at the time. Positional release is thought to relax, heighten muscle spindle, and interrupt feedback loop. Whereas pressure release is thought to actively unlock the actin and myosin chains in the ATP energy crisis. The underlying mechanism for active release is both the pathophysiological and histological mechanisms that still to this day remain largely unknown. One theory is with active release, there is an activation of mechanoreceptors which produce inhibition in the central nervous system. Another component of active release is that there is a chemical response. This chemical response produces an analgesic effect from the release of endocannabinoids. Endocannabinoids are released when the CNS is inhibited. And back to dry needling, this treatment is thought to address the central sensitization. And looking at the work of Segura Orti et al., he notes augmentation of the responsiveness of central neurons to input from nociceptive endings. Central sensitization can change, distort, or amplify nociceptive information in a manner that no longer directly reflects the specific quality and quantity of peripheral noxious stimuli, but rather the particular functional states of circuits in the central nervous system. So how does this information all apply to our treatment goals? Looking at the underlying mechanism in choosing the appropriate treatment, we also combine it with the treatment goal. So for instance, positional release. This is thought to reduce positional pain, so more likely to be successful in treating chronic conditions, chronic low back pain that may present from prolonged sitting or prolonged standing. Positional release is very helpful in avoiding spasming and guarding. So if we are working with a patient that has a natural response to guard passive stretching, this may be an alternative treatment that is successful. Looking at the treatment goals of pressure release, we know that the research shows decreased pain associated with latent and active trigger points, and this treatment is encouraged to have stretching followed immediately after to reinforce newly established muscle activity. One of the goals of pressure release is improved range of motion, which is also a goal of active release. Active release will restore dysfunction of subacute injuries. So somebody that's probably moved from the inflammation stage to the proliferative stage of healing. And lastly, dry needling has a unique goal of hopefully reducing symptoms in fewer treatment sessions. So this may be appropriate for a patient that can only come to the clinic once a week or once every other week, or possibly a patient that has a limited amount of visits per insurance considerations. So when we look at the treatments, we should take into account the treatment goals. Looking at application of each treatment, starting first with positional release. Positional release targeted at the tender points or myofascial trigger points will be a submaximal force applied by the clinician. Once the submaximal force is applied, the patient is then passively placed in a position of relief. The force of the submaximal pressure will be maintained until the clinician either feels the spasm subside or the patient reports a decrease in the symptoms. As you see, it requires the patient to speak up and let the clinician know what's going on. So that explains why I consider this more treatment that involves or requires more patient involvement. Once a patient has reported a decrease in symptoms or spasm, then another application can be applied. Ideally, each application or each position is held for 90 seconds. And depending on if the treatment is applied to a single body part or the whole body will determine the length of session. So for instance, if we are treating low back pain and we are just looking at the erector spinae muscles, it could be a treatment of 10 minutes. However, if we do this treatment as indicated with a whole body scan, we may be working the latissimus, the rotator cuff, the glute maximus, piriformis, hamstrings, gastrocnemius, and soleus. If we do the whole body approach, treatment will probably last 2 hours. The frequency of this treatment has been found effective in 6 to 8 sessions. And between sessions, the patient can be educated on a self-applied treatment to help alleviate symptoms that may come between sessions with the clinician. The main thing to note that is unique about this treatment is that the patient should avoid vigorous exercise 24 hours post-treatment. Therefore, if a clinician is working in the traditional setting of treating athletes, we should not be applying this if we have a conditioning session scheduled the next day, or if there is a major competition that the patient has decided they will participate in and not sit out. Going back to pressure release, let's look at the application of the treatment. The clinician locates the trigger point, applies pressure until the clinician feels that the top band is released. The pressure is then reapplied at an increased rate or increased depth, and this pattern continues until the trigger point is no longer palpable. This takes a lot of clinical expertise, as you can see here. I wrote that the main thing is to avoid heavy pressure that exacerbates ischemia. We do not want to contribute to the ATP energy crisis, which, if we block blood flow, could happen. This treatment is repeated in a sequence of 3 times per session, as found in some literature. Another report has standardized it for time versus reps and has found success with as little as 10-minute applications. Frequency can be applied 1 time a week for 2 weeks with positive results. Looking at active release in our application, this also is like our positional release. Our active release is going to have a submaximal pressure. The clinician is not going to put a lot of force on it, on the tissue. Pressure is maintained while the patient is taken from a shortened position to a lengthened position. If we look at it from mechanical force, we can see the submaximal pressure. We are compressing the tissue with our hands or a tool. Then we are applying tension by bringing the tissue from a shortened to a lengthened position. This application with the compression and tension combined is thought to be the underlying theory of active release. Active release will be applied for 5 to 20 seconds in 3 to 5 sets and can be repeated 2 times a week for 3 weeks with positive results. And lastly, dry needling. The reason I included dry needling in this presentation is the fact that I have very little background with it. I have not been trained in it, nor do I have much experience working with other providers who have done it. So therefore, a completely new technique. I wanted to compare it to things that I am familiar with, including active release and pressure release. So with dry needling, looking at treating the myofascial trigger points, the goal here again is to reduce the symptoms in fewer treatment sessions. So if a clinician is not comfortable with applying dry needling, then finding a clinician that is comfortable in dry needling, and if insurance is a consideration, this may be appropriate because it requires less visits and therefore less cost to the patient than, let's say, if we're billing for active release or pressure release treatments. Dry needling is commonly applied by taking the needle and inserting it 10 to 15 millimeters into the tissue to evoke a twitch response within the muscle. The needle is then pulled in and out fashion and repeated until the twitch response resolves. The patient and the clinician should both feel the twitch response subside with the in and out technique. This technique has been found successful with 2 treatments applied at 1 time a week. And another study also showed success at 1 time a week when applied for 3 weeks. Looking at a comparison head-to-head, I chose positional release and pressure release. And this article was by Shawabaka al. And it was a positional release technique versus manual pressure release on the upper trapezius muscle in patients with myofascial pain dysfunction syndrome. So looking first at the positional release. In this study, positional release was applied submaximal pressure, and this was measured by rating 70% of pain report. So the clinician applied pressure until the patient or subject rated it at 70% of what was rated at the pain pressure threshold. This was maintained for 60 seconds, and if at any time the symptoms decreased by 30% on the rating, then the clinician increased pressure until it was back up at the 70% of the reported pain pressure threshold. The second and third groups in this clinical trial, the second group was the pressure release group, and they were seated, where the clinician applied pressure, then passively moved the neck into cervical extension, side bend to the same side, and then cervical rotation opposite side, and remained in this position for 90 seconds. The third group in the trial was a control group, and as the author states, the control group did not receive any treatment or manual sham procedure as a control group. Each group had 15 patients. Overall, the study looked at 45 participants ranging in age from 20 to 33 years who had a presence of trigger point in the upper trapezius and complained of decreased neck range of motion. Participants were pooled or recruited from the Faculty of Physical Therapy at Cairo University. So I don't want to make any inferences on this population, whether they were physically active or sedentary. The authors did not go into patient demographics as far as their physical activity status or their amount of sitting or desk work per day. So it is hard to make assumptions on why they had trigger points in their upper trap. Participants were excluded if they had whiplash, any history of surgery of the neck, fibromyalgia, nerve entrapment, or previous myofascial treatment within recent weeks. So looking at the results of the 3 groups, the positional release group showed improvements from pre to post intervention in trigger point sensitivity, and neck range of motion improved in flexion, contralateral side bending, and ipsilateral rotation. The pressure release group showed improvements pre to post intervention in improvements in range of motion of flexion, extension, and contralateral side bending. When a between groups analysis was completed, then it was shown that the pressure release was more effective in increasing pain pressure threshold and cervical range of motion of flexion, extension, and contralateral side bending. So when treating the upper trap, this study should be considered when choosing the appropriate manual therapy. So to summarize with the article from Al-Shawabaka al. And all the other literature presented today, it is important that the clinician choose the appropriate myofascial release treatment by first determining the length of injury. As stated, any injury that is in this subacute stage may have a better response in active release. Somebody that has a chronic injury, positional release may be more effective. Other things the clinician should consider besides the length of the injury is a symptom presentation. If the patient is guarding and not responsive to passive stretching, then positional release may be a better treatment method than active release. Level of patient involvement should also be examined. The clinician should speak with the patient firsthand or first thing in describing these treatment methods and ask for their input. My personal experience as a clinician is there are some patients that don't want to speak up and just want to relax during their treatment. They'd rather have the clinician make all the decisions. And so in that case, clinician controlled treatment of pressure release may be better. If the patient likes to speak up and likes to give feedback to the clinician, then positional release and active release is a good treatment in order to encourage that patient to be involved in their therapy. Other things we should look at when determining a appropriate myofascial release treatment method is to look at the patient demands and goals. Again, positional release may have some soreness last for up to 48 hours. So therefore, we do not want the patient to have positional release if they have a strenuous activity plan for the next 1 or 2 days. Looking at clinician comfort, of course, is needed as well. For instance, even though I've done my research on dry needling, I have not had any formal training in the application of it, and therefore I would not be comfortable applying dry needling to a patient. Whereas I do have a lot of experience with pressure release and active release, so I do feel comfortable in explaining the treatment method and application of it to patients I may work with. Positional release is one that I've attempted for a few different body parts, but it is one that I typically do not gravitate towards. So I would need to practice this more before applying it to the patient population. So to summarize our clinical implications of these different myofascial release techniques, let's take into account all these different areas in order to effectively assist the patient in their goals. And I've included my references as well in case there are any questions. Thank you for your feedback and have a good day.